this next I invite my colleague, in fact, Dr. Subina Narang. She will be providing us, she will be on FFA and autofluorescence both. Dr. Subina.
Thank you. Stations to be covered, so I would be just touching upon each of them. And fluorescein angiography being more basic, I will have more slides of fluorescein angiography. And it we know is a very pertinent investigation as far as retina practice is concerned. So my first part of the talk is going to be basics of FFA, followed by basics of autofluorescence. So FFA, here we inject the fluorescent dye, which is 80% protein bound, and then we take images of the fundus where we see the coursing of the dye through all the retinal vessels. The absorption of light energy of blue wavelength is there, and then the vessels, they fluoresce out. The dye fluoresces at green yellow wavelength. The photographic images have given way to digital images. Of course, we can that's a quicker method, and we can do modifications of these images, enhancements can be done, and these can be shared instantaneously by our internet facilities. So thus we have shifted to digital imaging. Now this is what a normal fluorescein angiography would be. We will have hyperfluorescence or whitening, as Mohit very nicely explained. Hyper is going to be whitening wherever we have the dye. It's going to be whitening of the disc and the blood vessels, and the fovea appears to be dark, which is same dimension as the macula, as the optic disc, 1500 microns. And why it appears dark is because it has the photoreceptors are taller here. You have more of xanthophyll pigment, which blocks the fluorescence, and you do not have blood vessels or foveal avascular zone. To understand fluorescein angiography, you must understand the phases of fluorescein angiography. Once you push in the dye, it takes around 9 to 12 seconds to reach the eye. And then you have, initially the choroidal vessels would get filled, and you will have choroidal flush. It starts appearing at 10 seconds after you inject the dye in younger patient. In older patient, it could be slightly longer. Then there's arterial phase. The arteries of the retina are filled in with the dye, followed by the capillary transition phase a second later, then early venous phase, which appears as a trilaminar flow due to the plasma flows towards the side of the vessels. So you have this trilaminar flow. I'll be showing you the pictures. Arteriovenous phase is next, 16 to 70 seconds after dye injection, late venous phase. And then you have recirculation phase, when the dye is kind of getting washed away from the eye, and the lesions can take up the dye, which are pooling or staining of the dye would be there. So if we see the arterial phase, it just begins 1 to 2 seconds after the choroidal phase. Here you are seeing irregular patchy hyperfluorescence at the posterior pole, which is the choroidal hyperfluorescence, plus the arteries have started getting filled in, which is 9 to 12 seconds after the injection of dye. And then this is the early venous phase. You can see the trilaminar flow of the veins. You can see you have this dye towards the side, and the center one is hypofluorescent area. So this is early venous phase. Once you look at that, you need not look at the time frame. You would just say it's the early venous phase. And then there's increase in patchy choroidal hyperfluorescence here. Peak arteriovenous phase is when the veins, artery and veins both are equally filled, and you have this the choroidal vessels. There's a uniform choroidal hyperfluorescence for the choroidal vessels. But mind it, fluorescein angiography gives us the retinal vasculature information. We hardly get any information about the choroidal vasculature in this. Arteriovenous phase, I think I've already covered it. So there's increase in choroidal hyperfluorescence, as well as arteries and veins are equally filled. And then is the recirculation phase, where you see that the dye is almost fading away. So these are all the frames. So whenever you look at any fluorescein angiogram, you're going to look at all these phases and comment in the end. And whatever it is, either it would be hyperfluorescence or hyperfluorescence. And this, if you know the blood retinal barriers, which is the outer blood retinal barrier and inner blood retinal barrier, you would be able to tell what disease, what pathology are we dealing with. Now Now, whenever you are reading fluorescent, it has to be hypofluorescence or hyperfluorescence. Never jump to the diagnosis. Just say, I am seeing this phase, like this is arteriovenous phase, and I am seeing hypofluorescence corresponding to which area, which you would be telling superior-temporal to macula, which superior-temporal to fovea, which is then you, according to the disc diameter, you speak about what is the size of this lesion. And then you also have hyperfluorescent area. That also you comment about. Hyperfluorescent area, what area it is. It is in the center of the fovea. You are seeing hyperfluorescence. So hyperfluorescence can be leakage, staining, pooling, or window defect. If it is hyperfluorescence is increasing from early to late phase, it is either leakage or staining or pooling of dye, which you will be seeing in subsequent examples. And or it's window defect. In window defect, what will happen? It's the window and it's the choroidal fluorescence which is showing. So it would increase and finally it would fade away in late phases. So this thing, if you know, you would be able to comment what kind of hyperfluorescent lesion it is. Let's see a few examples. Here you are seeing pinpoint hyperfluorescent lesions in the macula, and there is increasing hyperfluorescence. The superior temporal hyperfluorescence is increasing in subsequent phase. At 72 seconds, it's like glowing like a bulb. And you also see these small dot-like hyperfluorescent areas. These are also showing increase in hyperfluorescence in the late phase. So that's how you describe an FFA. This was proliferative diabetic retinopathy with neovascularizations elsewhere and diabetic macular edema. Now this is early phase. You say this is the arterial phase. It is showing some small hyperfluorescent, pinpoint hyperfluorescent inferior to the fovea, and this hyperfluorescence is increasing in size as well as intensity. It's further increasing in size superiorly, and now this is known as smokestack sign, which is very classic for central serous chororetinopathy. This smokestack sign is due to convection currents which are present. Then there are other, of course, pathologies, other ways CSCR can present. It could be expanding ink blot pattern. This small pattern has, this small dot has got expanded. It could be smokestack. It's just the beginning of smokestack. Ultimately, you'll have what you saw in the last angiogram. And this is again, this is very classic example of you're seeing increase in hyperfluorescence. Here on top, it's just increasing in intensity. The size is not increasing. So this is pigment epithelial detachment. And this lower down, one thing is you are seeing one small dot which is increasing in size as well as intensity. So this is leakage and suggestive of ink blot pattern. And this is again the lower down again is leakage. Now this is 32-year-old male presenting with decrease in vision, and if you do fluorescein angiography, this is the arterial phase. This is showing, what is this showing? This is what lesion? Hypo or hyper? This is hypofluorescent lesion which are seeing in the posterior pole, which are placoid lesions. Some are confluent, some are discrete, and if you see the late phase, these lesions become, everything is hypo or hyper. This is hyperfluorescent, very right. So this is quite suggestive of active choroiditis, multifocal choroiditis patch. Hypo, which becomes hyper later on. Now hypofluorescence can be blocked hypofluorescence or it can be hypoperfusion. Blocked hypofluorescence, it is present in all phases of angiogram, does not decrease or increase in size. It stays the same because it could be pre-retinal, it could be intraretinal. You could see the retinal vessels, you may not see the retinal vessels. Then hypoperfusion, it would decrease in the later phases. First you see, I would just show you examples. If you look at this, this is the early frame. You are seeing hypofluorescent lesion which is inferior to the disc, and along the vessel, it is in fact blocking the vessel also at places, and this is persisting in late phases. So this is blocked fluorescence due to hemorrhage. Right. And if you look at this, again you are seeing areas of, there's area of hypofluorescent with pinpoint hyperfluorescent areas also, right? This is hypo, which is decreasing in late phase. If you look at this and you look at this, the amount of hypofluorescence has decreased. So this is capillary non-perfusion, and at the same time you are having areas of hyperfluorescence. So surrounding this microaneurysm, there is edema and it is leaking. So this is branched retinal vein occlusion. And this is lacy hyperfluorescent in the center, which is increasing in subsequent phase, arteriovenous phase, and this is in late phase it becomes increase in intensity as well as size. So this is what? Leakage. This is leakage of fluorescent dye, and the cause is choroidal neovascular membrane. Now we have angiogram looking at all the things, but all of us cannot afford that octa. With octa you see where the vascular plexus is. Now this is a beautiful example. You see some hyperfluorescence here, patchy hyperfluorescence, but you do not get exactly what area is leaking. And if you see the late phase, in fact there is definite increase in size and of the lesion as well as the intensity. So this is something which is occult CNVM. And if you see on top, there is hyperfluorescent area which is again increasing in hyperfluorescence in late phase, but there is no increase in size. So this is the staining of the scar. This part is staining and this part is leakage. So there is active CNVM plus this is a scar, probably a laser scar or something, which or maybe pre-existing, and this is not leaking. This is staining. This is, you have blocked fluorescence as well as increasing fluorescence in the same one. This is CNVM. Then something like this where FFA scores or over other modalities OCT. If you look at the FAS here, you see the FAS is not regular. It is FAS, the distance is more and it's not regular. Irregularity of FAD, and you are seeing the capillaries and arteries, they are just stopping short here, they are irregular. This is diabetic macular edema, which is ischemic, diabetic macular edema with ischemic macula. You are seeing microaneurysm which are leaking, but the macula is ischemic. This is another nice example of choroidal granuloma. Here you see that there is hypofluorescence in the beginning. You see this is the early venous phase. You see trilamellar flow. This is hyperfluorescence, which is due to block fluorescence due to mass lesion. And then as you progress further, there is increase in the patchy hyperfluorescence increases, and you see the vessels, they become leaky, and there is some staining of the vessel wall also, which is suggestive of inflammation. And lower down there is leaking, which is the late phase where it has the hyperfluorescence has increased. So this is very classical for choroidal granuloma. Now if you see here, all the vessels have not started getting filled. It is the superiotemporal vessel is not filled as yet. So this is a filling defect is there. It would fill at a later date. But if you see, the retrograde filling has already started. From these vessels, the retrograde filling from the filled vessel starts. And ultimately, if you see straight the late phase, you will never be able to see whether it's BRA or not. This was branched retinal artery occlusion, but you have to catch this in early phase so that you can see this delayed perfusion. And later on, you have this boxcar kind of appearance, which is there in the vessel if you see. This is again very classic exam and come out with a diagnosis. What is this? This is early frame. It goes on increasing the hyperfluorescence in the late phase. So this is leakage.
She's written the diagnosis. At least read out and see. Subina, you may have to hurry.
Yeah, I think so. I'll skip that video. Autofluorescence, it describes the appearance of fluorescence from the fundus, which is captured before you inject the intravenous dye. It's a non-invasive procedure. That's how it scores over FFA, and it gives functional information about retinal pigment epithelium. Lipofuscin is the principal source of autofluorescence. So it originates from the phagocytosis of the photoreceptor layers of photoreceptor outer segment layer. And the important component of lipofuscin in RPE cells is A to E, which is a combination of vitamin A as well as ethanolamine, which leads to autofluorescence. So this tells you about the health of retinal pigment epithelial cells. You excite this is the same as FFA. You have the light it excites is 430 to 600 nanometer, and then what you get back is 480 nanometer and 800 nanometer. And then what is normal is the central dark area, which is the attenuation of autofluorescence by RP, melanin pigment, and apical size or the side of our apical side of RP. And macular pigment is also present, which also leads to some hypofluorescence. It is seen that gradually there is decrease in autofluorescence towards the periphery. And in case you see the autofluorescence of aged people, it goes on increasing with time because you have more and more of lipofuscin getting collected there. And FAF distribution roughly matches the distribution of photoreceptors of rod cells. Now this is what a normal autofluorescence is. You have optic disc, which is dark area, you have vessels, which is dark area, and you have central macular area, which is again dark area. The bright area, these are drusen's are bright area, or anything with lipofuscin is collected is bright area. Increase accumulation of lipofuscin in RPE cells is going to lead to the bright autofluorescence, and excitation of lipofuscin is at 630 nanometers, I have already told. Areas that are white are the markers of increased risk of atrophy at a later date. Reduced autofluorescence is seen in absence or reduction of RP cells, lipofuscin in RP or RP atrophy, or increase in melanin. Luteal pigment. Now this is a geographical atrophy. You see that you can monitor these cases. We have geographical atrophy. You can monitor them on autofluorescence only. The area would go on increasing at subsequent visit, or what your aim has to be to halt the progression of this increase in hypoautofluorescence. And then this is the drusens. They are also increased autofluorescence is seen in drusens in ARMD once you have the membrane, or dehemoglobinized blood. Anywhere where you see intraretinal fluid, that also leads to increased hyperautofluorescence. This is the geographical atrophy, ARMD, as well as drusens. The drusens are appearing as hyperautofluorescence, and the atrophic area is hypoautofluorescence. Now sometimes in a busy clinic you could miss on these white dots which are there, but you do FAF, you see these beautifully hyper and hypoautofluorescent areas. Now if you do FFA, you would see that these areas are leaking in the late phase, hypofluorescent and hyperfluorescent. This is a case of choroidal osteoma. You have fluid collection here, and you have serous detachment is showing as hyperautofluorescent area. And then we monitor them after giving anti-VEGF on autofluorescence only. You keep on seeing decrease in this as the fluid goes on decreasing. CSCR, now there's another thing which has come up is that this is FFA showing the leak, because in case you want to laser that, your your autofluorescence will also show as hypoautofluorescent area. The leaking point is seen as hypoautofluorescent on FAF. Macular hole, this will show you that as there's nothing on top, there's no blocking effect, you see hyperautofluorescence area here, but later on if you do macular surgery, this hyperautofluorescence, it decreases. Chloroquine toxicity, very classic. You see this is a classic pattern which is easily picked up on FAF and not picked up many times on FFA also. This is another case which is just showing to monitor the progress of Farouk. I think I did show hyperautofluorescence and hypoautofluorescence. Now this is a case of CNVM. You see hyperautofluorescent lesions along with hypoautofluorescence. Hypo is already dead RP, and this hyperautofluorescent is suggestive of activity, and these are the areas which are going to be read the next. CNVM, hyperautofluorescence. Summarizing, FFA should be read sequentially and interpreted after seeing all the phases. You should see the timeline, and FFA tells about the function of blood-retinal barriers. FAF is an important tool to tell RP health and can be used. It's a non-invasive method to monitor these patients. FFA and FAF, the important diagnostic tools, but must be read in complement with the clinical examination. Clinical examination is a must for all the cases. Thank you very much.
Thank you very much, Subina.